Hello friends, welcome to another session of Radio Shots, and today we'll be talking about another very interesting case of an elderly female who came to us with pain abdomen. Now this patient had a history of gallstones, and this is the reason why we were suspecting a gallbladder pathology. The patient was initially sent to us for an ultrasound of the abdomen, but there was something wrong with her abdomen which led us to do a CT for her. So this is the clinical detail: a 54-year-old female with pain in right hypochondrium and presence of gallstones, thus raising a possibility of a gallstone disease. So let's have a look at the sonographic image first. So this is the cine loop, and I hope all of you are going to agree with me when I say that the primary pathology is the gallbladder. The gallbladder looks abnormal. I think all of you can appreciate the calculi, the sludge inside the lumen, but I also want you to have a look at the gallbladder wall, the adjoining areas, the subhepatic fat, and the liver bed. So let's play this video once again. I hope you've already made your own observations. What do we see here? We can clearly see that gallbladder contains some calculi. It also contains sludge. Now, what is more important is the wall of the gallbladder. So if you see the wall of the gallbladder along the anterior aspect, can you appreciate a clear-cut fat plane which is dividing the gallbladder from the liver? No, there is no fat plane. The gallbladder wall here appears inseparable from the adjoining liver bed. Secondly, if you look at the gallbladder wall, it is not just thickened. We can see some cystic areas. All these are cystic areas which are located within the thickened gallbladder wall. And when I just scroll it towards the other side, I can see that here exactly one of those cystic areas is showing a loss of the normal mucosal outline, and it is communicating with the lumen of the gallbladder. So this is the basic pathology. Gallstone disease, obviously, presence of gallbladder sludge, thickening of wall, plus presence of cystic spaces within the thickened wall of the gallbladder. Now, let's come outside the gallbladder and look at the adjoining structures. When we look at the adjoining liver bed, one thing that we've already seen is that there's no clear-cut fat plane which is dividing the gallbladder wall from the liver bed. But when we look at the adjoining liver parenchyma, it is appearing slightly hypoechoic. Now, this hypoechoic appearance of the liver parenchyma may be because of two reasons. Number one is some form of an infiltration. And number two, it can be because of edema. So looking at this particular image, it is difficult to say whether we're dealing with an inflammatory process or a neoplastic process. But when we just move a bit further down, what do we see? We see that this fat. Now, this fat is located where? Look at this liver parenchyma. So, this liver parenchyma is ending here. In fact, it is the inferior edge of the liver or inferior border of the liver. What do we see along the inferior border of the liver? You must have seen this diagram of liver with gallbladder protruding through it. So, what is present here? This is nothing but the subhepatic omental fat. Now, if you see the echogenicity plus the nature of this fat, it appears to be somewhat abnormal. It appears to be abnormally echogenic compared to the fat here, and here, as well as here. Now, this abnormal echogenicity of the subhepatic omental fat is because of inflammation. It means that probably we are not dealing with a malignant pathology, but we're dealing with some form of an inflammatory pathology. Then, when I'm just completely ending the video, I don't see any area of a pericholecystic collection. Some of you may argue that this cystic area that we're seeing are nothing but intramural abscesses. That do happen in case of complicated cholecystitis as well. But the patient did not have history of fever. The patient was not toxic. There was no septicemia. So possibility of an intramural abscess was slightly lower in our case. So we kept the possibility of some form of a complicated cholecystitis, and the possibility of malignancy was kept lower down. What to do next? The next thing to rule these things out was to do a CT scan. And now we'll be having a look at the cine loop of the CT scan of the same patient. So this is the cine loop of the CT of the same patient. So what do we see here? When I'm going from top to bottom, I can see that the gallbladder wall here is thickened, definitely thickened. And when I'm going down somewhere here, exactly, I can see that there is loss of that mucosal integrity. I hope all of you would be able to appreciate this. We can see this enhancing mucosa all throughout. We can also see the hyperdense calculus within the lumen, but do we see any mass lesion? No. the wall thickening or the wall thickness of the gallbladder is homogeneous throughout. It doesn't look like a malignancy. Plus, we can also see some inflammatory reaction in the subhepatic omentum, something that we picked on the ultrasound only. So this stranded fat which is present along the inferior margin of the liver is nothing but the inflamed subhepatic omental fat. Now let's have a look at the most important static images, the axial and the coronal reformatted images of the same patient. So here we have the coronal reformatted image and the axial image. In the coronal reformatted images, what can you see? I hope all of you can appreciate this significantly thickened gallbladder wall. So the first finding is diffusely thickened GB wall. And we can also see some regional inflammatory changes. You can see some fat stranding in the subhepatic omentum. So we can see some regional inflammation. Now, does it look like a malignant pathology to you? To me, it doesn't look like, because I can see that it is showing very clear-cut demarcation between the adjoining liver and the thickened GB wall. It still can be malignant, but it should show some infiltration. There is homogeneous thickening of the GB wall. We've talked about this before. Whenever you see an eccentric, asymmetric, irregular thickening of the gallbladder wall, that is more likely suggestive of malignancy. But if you see a diffusely thickened gallbladder wall, it's more likely suggestive of some inflammation. The same features can also be appreciated on this axial image. What can you see on this axial image? On this axial image, you can see again a diffusely thickened GB wall, something that we've already seen. Also, we can see that within the thickened GB wall, there are multiple hypo-enhancing areas. So we have hypo-enhancing areas in GB wall. And these areas are usually small areas. I mean, not much. They will vary somewhere between 5 to 20 millimeter in size. There is some pericholecystic inflammation, but the fat planes appear to be maintained. So now if I ask you, what is the diagnosis? Is it an inflammatory pathology? Is it a neoplastic pathology? And is it some special pathology or not? Before I tell you the answer, I would just share with you another case whom I saw around 4 years back. Now, this was a relatively young male, 25 years of age, and when I did the sonographic examination, I could see that the gallbladder wall was diffusely thickened and significantly thickened. You can see the wall thickness is going up to the level of 25 mm. And we can see the similar findings. We can see some cystic areas which are fluid filled within the GB wall. Also, in this case, we can see that the mucosal integrity of the gallbladder is maintained. When we examine the same case of gallbladder in the transverse plane, that is in the axial plane, you can clearly see that this is the lumen of the gallbladder, and all surrounding the lumen is nothing but a thickened GB wall, and in the GB wall we can see some cystic areas. Now I want you to tell me the diagnosis, and before I tell you the diagnosis, I want you to have a look at the CT images of the same patient. How beautiful this gallbladder is looking. It's typically looking like a pear-shaped gallbladder. The mucosal lining is intact. This is the outer wall, and within the inner and the outer wall, we can see some cystic areas. So by now, I hope all of you would have made the diagnosis. This is a very important spotter question. This is a case of xanthogranulomatous cholecystitis. Now, this is one of those conditions which is many a times mistaken for malignancies, because you can get a significantly thickened GB wall. It is more common in females between 6th to 8th decade of life, and is characterized by the presence of small cystic areas within the thickened wall of the gallbladder, which are nothing but the occluded and thereby infiltrated Rokitansky Ashkoff nodules. So this is endometritis cholecystitis, which is nothing but a special form of a plain cholecystitis, not a malignancy. Many a times you can develop superadded infection because there are cystic areas, and these patients are more prone to develop abscesses as well as fistula formation. Now, before we completely end this topic, let's have a look at a case which is taken from literature. How will the same look on an MRI? On the MRI, it is going to mimic the same features as we saw on CT as well as ultrasound. We can see that again, the gallbladder wall is significantly thickened. We can see some hyperenhancement of the adjoining liver parenchyma because of the adjoining inflammatory process. And we can see these cystic areas within the thickened GB wall all throughout, which are seen on T2 weighted sequence, on T1 weighted sequence, on post contrast sequence. We can see that the wall is enhancing very well, but we see these cystic areas which are non-enhancing. Another very important feature of this disease is the intact mucosal lining. Although in our case, we could see a breach of the mucosal outline. However, the patient was operated and on histopathology, our diagnosis was confirmed. Before we end this session, there is another very important special case or a mimicker which I've also taken from the literature just for giving you an extra edge. What do you think it is? Now, this type of a gallbladder is very different. Why? Because it is very hypointense on T2 weighted sequences. Usually, in all forms of inflammation or edema, you expect a hyperintensity in the wall of the gallbladder. But this gallbladder wall is so hypointense on T2 weighted sequence, it is nearly iso-intense on T1 weighted sequence, and you can see the central core is not enhancing much on post contrast sequence, but only the outer layer of the gallbladder wall is enhancing. So if you see this type of a very low signal, what are the things which produce low signal on a T2 sequence? It can be some fibrosis, it can be some form of calcification. So it doesn't look like a calcification. Porcelain gallbladder presents with thin calcification. This is a special case of hyalinizing cholecystitis. And this is a rare case taken from this wonderful article, which you can go through to read about it in a much better fashion. So this is all about xanthogranulomatosis cholecystitis, the most important imaging features and how to differentiate it from malignancy.